Uh, Hello. So, in this video, that will be, of course, for my personal use, we'll study the last in the cardiac section of pharmacology of CVS Pharmacology, that are the anti-anginal drugs. So, what is angina? Angina is ischemic pain in the heart due to the blockage of the coronary arteries, and this chest pain will radiate to the arm and the back, and there will be sympathetic system symptoms seen with this, like sweating and tremors. So there are three types of angina: stable angina, unstable angina, and prince metal angina. Stable angina is also called classical angina or exertional angina. I- in this, you'll see there's the arteries, and it has its endothelial cells, but between the in the right coronary artery, and there will be some formation of blockage, and uh, if this blockage is more than 30%, if then it will be called stable angina. And like in stable angina, the blockage is more than 30%. So the clinical features are: the person at rest will be normal, will have no problems, but on exertion, the oxygen demand of the heart will increase, because of which there will be increased sympathetic symptoms, and there will be increased chest pain due to ischemic, due to insufficient blood supply in the heart, which will cause some ischemic pain, and this will lead to anginal pain. So yeah, the chest pain is the anginal pain. In unstable angina, the it is a part of the syndrome called as acute coronary syndrome. In this, there is a atherosclerotic plaque formation below the and the endothelial lining is damaged. The endothelial lining is damaged, and there is a atherosclerotic plaque formation. And in atherosclerotic plaque formation, as there is endothelial damage, there is a thrombus formation due to platelet aggregation on the damaged part of the endothelium, which leads to critical narrowing of the blood vessel. And this this case of unstable angina is managed as a myocardial infarction. And in this case, antiplatelet drugs like aspirin is the brand name, but antiplatelet drug as aspirin is really important in unstable angina, which is managed as myocardial infarction. And lastly, there is prince metal angina. So uh, prince metal angina is also known as vasospastic angina or variant angina, in which there is endothelial dysfunction and the blood vessel will vasospasm. So that is why it is also known as vasospastic angina. And there will be pain at rest for the patient in this angina. So, what is the drug of choice for acute angina? For acute angina, the drug of choice is sublingual nitrates like nitroglycerin, which is given sublingually 0.5 milligrams, and the sublingual tablet is kept below the tongue. You can also give ISDN or isosorbide dinitrate 5 milligrams sublingually. So the drug of choice for chronic, and let's study about the drug of choice for chronic angina. So if it is a chronic stable angina, the drug of choice will be beta blockers, because beta blockers, they decrease the heart rate, so there will be a decrease in oxygen demand of the body. If beta blockers do not work, we'll give calcium channel blockers, the DHP type, which is the dipines like amlodipine, clinidipine, and many more. If they do not work, then there will be use of nitrates per orally or in through the transdermal route. And aspirin is also given prophylactically So stable angina does not mature and become an unstable angina. In chronic vasospastic angina, the drug of choice is the first choice is calcium channel blockers, DHP type, the dipines, and if it does not work, we give long-acting nitrates per orally or transdermally. So the management for drugs used in the management are the same for chronic vasospastic angina and chronic stable angina. But one major difference is the beta blockers which are used in chronic stable angina are contraindicated in chronic vasospastic angina. So as we can see, beta blockers are contraindicated because the beta blockers can produce vasoconstriction. And as we know, vasospastic angina or Prince metal angina, there is an endothelial dysfunction because of which there is vasospasm in the blood vessel. If we give drugs which cause vasoconstriction, it can make the problem worse. That's why beta blockers are contraindicated. So these let's study about the drugs that are given in the about two which we studied, CSA and CVA. And the first line drugs are beta blockers, calcium channel blockers, and nitrates. And the second line drugs are nicorandil, dipyridamole, ranolazine, ivabradine, fascidel, and trimetazidine. So if the first line drugs are given and they are not working and the angina is called resistant angina, will give the second line drugs. But in the second line drugs, dipyramidol is a drug which is banned and it is not used anymore as it causes coronary steal syndrome. And ranolazine was a second line drug at first, but now it is used as a first line drug. So let's study about the different drugs. So beta blockers is the first drug in the first line drugs we will study about, and the mechanism of action of beta blockers is it blocks the beta 1 receptors on the heart, so there will be a decrease in heart rate which will cause a decrease in oxygen demand. It is the drug of choice for chronic stable angina as we studied earlier, and the side effects of beta blockers is it also blocks beta 2 receptors with beta 1 receptors. So there's blockage of beta 2 receptors on the coronary arteries which will cause vasoconstriction, and this vasoconstriction will increase the risk of vasospastic angina or Prince metal angina. So we saw that beta blockers are contraindicated in Prince metal angina because they also have the property of causing vasoconstriction. So the cardioselective beta blockers are always preferred. So cardioselective beta blockers, they block beta 1 more preferably than beta 2, and non-selective beta blockers, they block beta 1 and beta 2 receptors equally. So the cardioreceptive beta blockers are all the metoprolol, atenolol, nebivolol, and bisoprolol. And non-selective beta blocker is propanolol. So that is why propanolol is absolutely contraindicated in vasospastic angina or Prince metal angina. Now let's study about the different calcium channel blockers in angina. So we use the DHP type of calcium channel blockers that are the dipines. So amlodipine, nifedipine, and felodipine. And the main mechanism of action of these drugs are they are coronary artery dilators. So they dilate the arteries, and this was the same mechanism of CCBs in reducing hypertension also. They are as the drug of choice for chronic vasospastic angina as we saw, because beta blockers are contraindicated, then we use the dipines, and if dipines also not work, we use a long acting nitrates per oral and transdermal, and we'll study about the nitrates later, but first let's see what are the calcium channel blockers about. The side effect of CCBs are, of course, reflex tachycardia, and reflex tachycardia will lead to an increased risk of stable angina, as reflex tachycardia will increase the heart rate and there will be an increase in oxygen demand of the body. So if dipines are combined with the beta blockers, they will prevent the side effect of reflex tachycardia, because beta blockers decrease heart rate and dipines increase heart rate, which is the side effect due to reflex tachycardia. So that is why it can be combined with beta blockers to prevent the side effect of reflex tachycardia. And non-DHP type of calcium channel blockers like verapamil and diltiazem, they also reduce the heart rate and oxygen and reduce the oxygen demand, and they can be given in stable angina, but they are not the drug of choice. And they're also a coronary dilator, so they can be given in vasospastic angina. But non-DHP type of calcium channel blockers are to be never combined with beta blockers, because as we see now, non-DHP type of calcium channel blockers, they decrease the heart rate, and beta blockers, they also decrease the heart rate, so the effects will be compounded and there will be a marked bradycardia in the patient. So that is why non-DHP type of calcium blockers like verapamil and diltiazem is never given with beta blockers. So the beta blockers are the drugs that end with lol. Now let's study about the third first line drug, which is nitrates, or basically organic nitrates. So the mechanism of action of organic nitrates are, they are venodilators. So calcium channel blockers are artery dilators. Like them, nitrates are venous dilators, so they only act on the veins. And uh, so it is this venous dilation is the main mechanism of action. They reduce the preload on the heart and they reduce myocardial contractility. uh, and because of the decrease in the myocardial contractility or the contractility of the heart, there is a decrease in oxygen demand. The second mechanism of action of nitrates is by donating nitric oxide. As we already read, nitrates are a free donor of nitric oxide, and nitric oxide, they dilate the coronary artery, and dilation of the coronary artery is useful in vasospastic angina or Prince-Metal angina. And third mechanism of action of nitrates is, there's a redistribution of coronary blood flow. So it diverts the blood from uh, non-ischemic area to the ischemic area. So non-ischemic area means the area which has rich blood flow, and ischemic area means the area that has poor blood flow. So this phenomenon is known as the Robin Hood phenomenon, and there is redistribution of coronary blood flow due to the nitrates. And this phenomenon is actually seen in nitrates, and it is also seen in the beta blockers. So let's study about the different nitrate drugs. So there are different nitrate drugs. The most commonly known is the NTG or GTN, which is glyceryl trinitrate, but better known as nitroglycerin. There is also ISDN, which is isosorbide dinitrate, ISMN, isosorbide mononitrate, and PETN, pentaerythritol tetranitrate. So let's study what are the routes they are given through. So nitroglycerin or NTG is given peroral, sublingual, transdermal, rectal, inhalation, and intravenous, but it is never given subcutaneously or intramuscular, because the reason is nitroglycerin is easily absorbed in the fat, and if given by these routes, they will be absorbed in the in the fats of the body instead of getting circulated in the bloodstream or getting absorbed in the bloodstream. ISDN or isosorbate dinitrate can be given per oral and sublingually. Isosorbate mononitrate is only given per oral, and pentaerythritol tetranitrate is also only given per oral. So the chemical nature of nitrates is they are highly lipid soluble, so they get absorbed in fat easily, and they are non-ionic drugs. The first pass metabolism is they are degraded by the liver, and they have a very high first pass metabolism. So that's why subrectal and sublingual and rectal is the best way, because they skip the first pass metabolism of the body, except in ISMN, which is isosorbate mononitrate, because it has no first pass metabolism in the liver. The nitrate with 100% bioavailability is isosorbide mononitrate, which is given per orally. So actually, ISDN or isosorbate dinitrate is actually an inactive or a prodrug, and in the body it is converted to isosorbide mononitrate, which is the active drug. And the shortest acting drug is sublingual nitroglycerin or glyceryl trinitrate, and the longest acting drug is PETN, which is pentaerythral tetranitrate. Amyl nitrate was also a nitrate which was given through the inhalation route earlier, and it was the shortest acting drug in the treatment of angina, but this drug is not used anymore because of the explosive nature of the drug. The amyl nitrate is still used in cyanide poisoning, but it is not used for the treatment of angina. So, what are the uses of nitrates? So, in angina, it can be used for stable angina, vasospastic angina, acute angina, and chronic angina. It can be used in myocardial ischemia, myocardial infarction, and acute coronary syndrome. Uh, it is used in unstable angina, non-ST elevation myocardial infarction, ST elevation myocardial infarction. Uh, in unstable angina and NSTEMI, we will use morphine, oxygen, nitroglycerin, aspirin. But in STEMI, for management, we'll use morphine, oxygen, nitroglycerin, aspirin, and also streptokinase. Streptokinase will be used for streptokinase is a thrombolytic, and it will be used to break down the thrombus. Uh, in acute left ventricular failure or pulmonary edema, for for treatment we'll use nitrates to reduce the preload, because nitrate is a venodilator, and we'll use loop diuretics, morphine, and nitroglycerin in the treatment regimen for acute left ventricular failure or pulmonary edema. And in abdominal colicky pain, we'll use nitrates because it relaxes the GIT muscle, so it will be used in biliary colic and esophageal colic. But we should remember that nitrates will not be given in renal colic pain. So this was all for the part 1. I will cover from the drug interaction of nitrates in the second part of the video. And just to reiterate again, this is just for my personal use, but if anybody finds it helpful, that will mean a lot to me. So if anyone is watching, thank you for watching. I know I'm not producing the best video because I'm just making it for my personal use, but even if it helps, you can maybe comment, and it will mean a lot to me. So thank you.